Good evening, and a warm welcome to our session with Abbott. We'll be discussing about calcium and more calcium. So we have an array of very experienced professional speakers who will be discussing their best of the cases related to the calcium coronary arteries. And also we have with us two expert panelists, and Dr. Dhiman Kahali, who is a senior consultant interventional cardiologist at B.M. Birla Hospital with 4 decades of experience in interventional cardiology, and he is also the cath lab director of B.M. Birla Hospital. We also have with us Dr. Shashank Borua, who will be joining. He's senior consultant interventional cardiologist and head of the department at Health City Hospital, Guwahati. So about our speakers, we have 3 speakers: Dr. Arindam Pandey, who is consultant senior interventional cardiologist at Medica Hospital, Kolkata, a good friend of mine. And we have Dr. Kripa Sindhu Maurya, who is also a consultant interventional cardiologist at BMRC Hospital, Barakpur, and Dr. Homokanti Datto. He's also consultant interventional cardiologist at Manipal Hospital, Dhakuria. So we'll be starting with Dr. Homokanti Datto. He'll be talking about a topic about learning from mistakes in orbital therapy. So it will be a 15-minute presentation. So over to you, Dr. Datta, for your presentation.
Thank you, sir. And thank you, Abbott team, for arranging such a beautiful seminar this rainy weather. So let me share my slides. I shall be discussing 2 cases. The first case of mine, I started the journey of orbital atherectomy around 1.5 years back when it came into Kolkata with a new gadget, definitely a new tool in the therapy of calcium in the coronaries. We were used to of doing rota, then IVL came. Then obviously we had a huge experience of doing other therapies as well, the cutting, scoring balloons and so on. But believe me, orbital is coming out as a beautiful interventional tool that helps us in managing the calcium so well. So my first case was a case of NSTEMI. He was an elderly person around 72 years, presented with a severe chest pain at the mid of the night. We did it, the angio, at the very morning because he presented around 4:30 a.m. And you can see the calcium sitting in the LED all throughout from the LMCA distal to the osteoproximal. There was tight calcium, almost tram track calcium from the LMCA to mid of the LED. So we first crossed the lesion, obviously, with the Sion, followed by we exchanged with the microcatheter, and the orbital wire were taken. We did the orbital atherectomy quite well because we planned for it beforehand, and the orbital was going well. We crossed from proximal to the distal LED with the 80 km speed. 5 to 6 runs were taken as the LED proximal and LMCA distal was around 3.5 to 4 millimeter vessel. It was, so we did it the proximal LED with the 120 km speed. So all the orbital went well. So we are happy. And believe me, I was there planning to go for an DEB that time because the DEB was a promising result at the elderly population. It was around 73 to 75-year gentlemen who had a colon cancer. So considering the bleeding risk and the NSTEMI, I wanted to minimize the risk of DAPT as well. So my preference was to go for a proper balloon dilatation, the bed preparation, followed by a drug-eluting balloon from the mid to proximal LMC as well. So we take out the fiber wire, exchanged again with the Sion blue, and you can result the post-orbital atherectomy. This was the final result of the LED. You can see almost from the distal LMCA to mid of the LED. After orbital, it had a great flow. So we serially tried for balloon dilatation 2, followed by 2.5, followed by 3 in the proximal LED. Up to 3, there was a good result. Believe me, it was extensively good, going well. So this was around the first or second case of orbital atherectomy in our hospital. So we are happy with the result that we can go with the orbital quite well. But here comes the most turning point of this case. So we prepared the bed distal LMCA to proximal LAD with a 3.5 into 12 millimeter balloon, NC balloon obviously. And after the balloon, we had a nasty perforation. You can see after the balloon, we had this result. So the first, I will stop here and I will further suggest that even after orbital atherectomy, we must always use the imaging first, followed by again re-preparation of the bed. Because if we do not for an imaging, there are calcium spicules, there are uniformity of the calcium, there are improper dilatation of the balloons are there, and that ultimately resulted in, you can see that nasty, can see the perforation. So we first tried with the balloon dilatation, again serial balloon dilatations for pretty long time, 30 minutes. Then we tried with a giant stent, so hoping that after placement of the stents and balloon dilatation, it will stop. But believe me, it did not. So we did not have that time the appropriate size of uh, cover stand. That time it took around half an hour to 40 minutes to come again. So always, if we are planning for an orbital atherectomy or rota, we must keep a shelf of cover stands at least be prepared, because anything anytime can happen. This was our first experience. So ultimately, after putting the cover stent, this was the cover stent, and it ultimately was saved. So the patient was saved quite well. There was no significant pericardial effusion. The PP was maintaining quite well, and the NORAD support was diminished in the very same day as well. And the patient was saved, and he is still alive. So this was the final result. Though the result was not good, because we first aimed for an orbital atherectomy followed by DEB. This ultimately turned out to be ultimately copper stain followed by, to some extent, TIMI-3 flow results, obviously. But the main thing is that the luck saved that day, that we had saved that patient. So learnings from this first case was that, number one, we must have an imaging tool prepared always, not go for an calcium breaking, whatever we are using, be it a rota, be it a orbital, be it even IVL, it may burst anytime. In the first IVL cases, we had a bitter experience as well. Then we learned gradually that it should be in the 4 to 6. So always imaging first, and the preparation of the bed, even in the proximal or distal part of the LMCA, we must under dilate in the calcium vessels, because if we go for an over dilatation, there is high risk of perforation or dissection as well. So in my second case, this is a recent case we did just 1 month back. So this was the RCA, and first we tried for the LAD. You can see the bad LAD calcium. This is again an elderly person, you can see, and again the LAD proximal, even the LMCA distal had a calcium, and it was a significant tortuosity as well. So LMCA to LAD, so we crossed the lesion, exchange with the Viper with the microcatheter. You can see, then we tried with the orbital. The golden rule of orbital is that you can go both ups and downs. So we first went up with the 5K speed to the down, then we again come back with the 80K speed from the mid to proximal LAD, and to bed preparation in the proximal LAD as well. We went for 120K speed. So the orbital will cut to and fro. It will prepare your bed, and the most important thing is that it will not produce any kind of slow flow and no flow if we compare to the rota. And there is hardly any chance of stacking the bar, because this is not at all a bar. It cuts in a different manner. That's sanding is the most important procedure. It differential sanding is the most important theory behind the orbital. So after the orbital, you can see the bed was prepared. So we did IVAS. Here we didn't make the mistake. The first step, I would rather suggest that every pre and post orbital run, we must have an imaging. So proper bed preparation, proper sizing of the vessel, the imaging for the calcium ideally should be with the OCT if you have, but you can have an IVAS as well to minimize the cost as well. Then we did serial balloon dilatation. You can see again gradual serial balloon dilatation, not in a hasty manner. We must go slow, gradually 2.5, followed by 2.75, followed by 3. Then we deployed a giant Sierra. This is a new upcoming stent with a very malleability. You can see that trackability is very good. So we deployed from distal LMCA to LED. We post dilated again serially. 3 in the distal followed by 3.5 and fought with the 4. You can see the result that this was the sorry, this was the final result. This is quite astonishing. So orbital is always good, always preferred. It modifies your calcium quite well. So this will help me in every cases what we have done in 10 or 12 orbital cases. We had a beautiful experience, good learning curves as well. But from the beginning to this kind of cases, we have learned that imaging is must. Proper balloon dilatation ideally should be tried with the newer balloons, if preferred. Proper exchange with a microcatheter, and the most important thing, proper sizing of the vessels and proper coronary imaging is mandatory and must. And always be prepared for the bad days. There must be at least cover stents should be available when we are going for any kind of calcium preparation or therapy in those cases. Thank you very much. Over to you, sir.
Thank you very
Thank
much,
you,
Dr.
Dr.
Daud. Very
Datta, for
nice
this
guest.
excellent
Uh,
presentation. I would like
yeah.
to welcome Dr. Kahali, who has just joined us, and he's probably
So,
seen the second case. Devanda, you have seen the second
yeah,
case?
I saw both the cases.
Both the
The first
cases.
case
Okay.
was
So
also very
you
good.
can
The
take off from
patient
here
was saved.
and discuss this case.
And any patient after atherectomy, any sort of atherectomy, whether it's a rota or it is orbital, can have such things. But it was well tackled. Of course, the result was not as optimal because we were in a hurry to. The operator did well and managed the patient very well. He was saved. So the flow was good, TB3 flow was established. So just one comment I want to make, that not only in calcified lesion, but in all lesions it can happen. So always we should have a covered stent of different sizes, and in charge of the lab, who is the director of the lab or in charge of the lab, cath lab, he should always inquire that okay, the cover stents of these sizes are there, the normal whatever the sizes, those sizes cover stent should always be available. It's irrespective of calcified lesion. Of course, in calcified lesions, as Dr. Shomo told, that because of the calcium spicules, the chances of rupture, dissection, etc. are more. But anyhow, it can happen with other lesions as well. Now we go for very high pressure balloon inflation, and I have seen in the best of hands globally that there was rupture, and even they didn't get any time to send the patient to the OT after holding with a balloon dilatation the ruptured area. So this is a life-threatening complication, and we should always be ready to deal with it by having covered stents of different sizes in our lab. This can save the life. All of us have the experience, and just waiting for 20, 30 minutes and making the area further ischemic is not good, but it does happen. So we should always be on our toes, and we should inquire at least once weekly that whether the covered stents are there or whether it has been used and whether it is in place or not. It's mandated. But it was very good case. Second case was fantastic. It was very well done. The flow was very good. The dilatation was good. It was also a highly calcified, very nasty looking calcification, but it was dilated well and the results were very good. Thank you, Shomo.
Dr.
Thank you,
Shomo,
sir.
can I ask you a
Yes, sir.
question?
Yes, sir.
Um, you uh, in this particular orbital atherectomy, the Viper wire actually sometimes, or most of the times, can be crossed primarily. You don't require a
Yeah,
wire.
yes, sir. Yes, sir.
So
It
in
can be
this,
crossed directly as well. We
yeah,
will not
yeah,
need to have the microcatheter always.
yeah.
In the first few cases, we are not habituated with the Viper wire. Then gradually we are habituated with the Viper wire, and we are even putting stents with that wire only. So it's a beautiful wire as well.
Only a disadvantage, I think, if you're putting a stent, because the wire is so long, to put the stent across,
It's
maybe
difficult to
at
exchange the
that point of
balloons
time
and
you may
yes, sir.
need. So
Yes, sir. That
primarily,
is
I think you can cross with the Viper wire, so that will save you the cost of the microcatheters as well. So
yes, sir.
that's one point. But as Dr. Kahali mentioned, it was done very well, And as he stressed that the covered stent in a cath lab is a must, irrespective of whatever cases you do, because in
Yeah.
today's world, we
Can
don't
I
do.
ask you, sir, both of you, sir, one question? So there is a dictum that 2.5 or 2.75 cover stents can be dilated up to 3.5 or 4. But in my experience, one case outside even it is very impossible to dilate with that hard stent up to 2.75. I had a 2.5, 2.75 cover stent. So
It's not
ideally,
well dilatable. It's not
yeah,
like the newer
it must have
generation
a lid.
stents that
So
from
ideal, yes,
3.5
sir.
you can go to 5. It's not
Yes,
like that. It's not that dilatable. And
yeah,
we neither should try because it's already an injured area. There is leaking of blood. And we should not try to injure it further by
yes,
dilatation
sir.
at a very
Yes, sir.
high.
So I
So we
waited
should have a
with the
3, 3.5 like that covers 10 different sizes. And we should not take a lower sized one. Of course, if it not there, then there is no other way out. That's something different. But it does not dilate well, whatever is written.
yes.
And in the first case, Dr. Datta, I think the orbital didn't do the perforation. That is something
No,
which
no, no.
needs to be
Orbital was
emphasized. Yeah,
absolutely safe.
yeah.
So it
So
was the
that needs
balloon
to be
dilatation.
emphasized that it was
Yes,
actually the balloon which did the
yes, yes,
perforation and not
yes, sir.
the orbital. So
Not the
What
orbital.
you said,
in
Dr.
these
Datta,
kinds,
you went for the dilatation.
Sir,
What
he
we
balloon
went
it
for
was? Ox
around.
balloon
It was
or
an
ox?
NC balloon. We were dilating around 16 to 20 atmospheres, sir. It
It
was
was
a
an ox
NC.
balloon or it was a NY?
No, the 3.5 was a new balloon.
New
The
balloon.
2 followed by 2.5 were ox balloons because I was planning for DEB in that case. So I had in my mind that I should prepare my bed in the same size. So it is ideally be if the bed preparation. If I putting a DEB of 3.5, the bed must be at least for 3.5. So I did it with the 3.5, but that the massacre occurs. So it is always preferred. Then we learn that gradually serial dilatations with the new balloons, obviously. And if you are planning for a DV, it may be preferred that you can under dilate as well, because in elderly person, just having a good T3 flow will be sufficient enough
No,
rather
it
than
was well
requiring.
done. Yeah, you
Yeah,
established Dimitri flow and
yes, yes.
everything was
yeah,
good. So in a hurry, you can't go more than that.
yes, sir.
That's perfect.
Thank you, sir.
Dimanda, can
But
we move on to the next
oversized or
case?
undersized,
Yeah.
nothing should be done in case of, these are very rigid stents, as you know. The side
Yes,
branches are sacrificed many a time. So
yes, sir.
we should
Thank you,
be
sir.
given
Thank
the
you very
proper
much.
size of cover stent, but we should ensure that every week I go and ask them that have you got the cover stent? Because the main problem is that hardwares are not available. Today we are doing one CTO and different balloons were not available. This was the ECHS, when CGHS type of patient, new balloons are not available. So it's a problem. Well, if it is a new NY balloon, then 1.5 year you will go into anything. But the polish is not lost over the wear. The balloons are like that. So you have to work it. Anyhow.
Okay, thank
Thank you,
you,
sir.
Dr.
Thank you, sir.
Datta. We will move on to our next presenter, Dr. Kripa Sindhu Maurya, and he is a consultant interventional cardiologist at BMRC Hospital, Barakpur, and he's going to talk about OCT guided IVL in calcified LED. So it's another technology he's going to discuss. Over to you, Dr. Maurya.
Thank you, sir. Good evening, everyone. Thank you for the thank to about team as well, Dr. Dhiman Kahali sir and Vinayak Dev sir for moderating the this case. And I would move on to my PPT. Yes. Is this visible, sir?
It's visible and audible also. You
Yes.
go on. Keep pushing.
Yeah, yes. So my today's case of discussion is on OCT guided calcified LED treated with the IVL. My case is 72 years old gentleman who is hypertensive, diabetes, and with a high bleeding risk, and having a history of GI symptoms and GI bleed with an old history of ischemic CVA. So patient is having a history of high thrombotic burden and high bleeding risk. Patient is have also suffered one episode of sudden cardiac arrest before that, and thereafter referred from the medicine consultant for the intermittent chest pain. And it was surprising. EF is 57 and no RWMA. ECG was normal, creatinine normal, USG abdomen was done normal, CAG done, which shows that critical calcified LAD and 95% lesion uh, in the proximal LAD, proximal to mid LAD, and it was calcified. So and it is left and dominant circulations, and LCX in the OM also there was a 90% lesion which was done. And initially I started with the plastic to the LAD, and but there was a dog downing happened with the 2 into 12 NC balloon while doing the PTCA. So it was the case was decided to postpone and to do with the OCT guided and AVL also. And thereafter I crossed the cyan blue and cross the lesion and pre-dilate with the 2 into 12. Thereafter, then pre-procedure OCT run has been taken, in which it shows that there is a critical significant calcium in this part, about more than 200-degree calcium, and we can see that there is a low scattering, back scattering, and there is low attenuation, and which clearly shows that there is a calcium. And so we can see that calcium is to much extent. And so thereafter and it is shown that calcium degree is more than 200, and thickness is also more than 0.5, and luminal area is less. So I put a IVL catheter of 2.5 into 12 inflated at the 4 atmosphere, and pulse is delivered 10 pulse, and then 10 again. After the 30 pulse, the IVL balloon ruptures, which was very surprising, because I thought that it would be a concentric calcium, but maybe some eccentricity was there. So maybe there is a thermal injury there, and the maybe non-uniform balloon expansion was there. So that can cause this event. So I was not able to take the OCT catheter at this moment due to risk, due to fear of dissection maybe inside. So I directly taken the Giants expedition and stented this portion, and then go with the OCT run. And then I saw that there was no edge dissection at all, and there was we can see that there is no edge dissection and there is no malapposition, but there was under expansion at this moment. So I had decided to post dilate it with the 2.75 NC at a high atmosphere, 18 atmosphere, and thereafter I got a good result. So emphasizing that it is not always possible to do the angioplasty with just a simple NC balloon. So imaging is must in almost most of all the cases. However, it is not possible for us to get this technology always. And also one more case to emphasize on the left ventricle LAD, where 48 years old gentleman who presented with the chest pain, EF normal, sinus rhythm, creatinine is okay, where it was a double vessel CAD with a distal left ventricle lesion. But we can see in the angio that lesion was there, but I was not able to get whether I should stent it from the left ventricle to LAD or only the just this from proximal part of the LAD, because there was also an aneurysm in the mid part of the LAD. So it was difficult for me to get whether I could put the stent from the left ventricle to LAD or just because there is a ostial part of the LAD was not involvement on the angiography. So I secure the LCX also, and at the same time I done the OCT run, where I can see that left main was involved, and the tightest portion we can see You can see the tightest portion, and from here you can see that there was no calcium, but there is a tightest part, and Lettman is also involved. We can see this is an aneurysm part where we can see that the diameter is about 4.5 to 5. So I do not want to put the stent over there. So OCT given me the idea where to put the stent, and also I got to know that I have to do the stenting from the Lettman as well. Thereafter I pre-dilate the lesions and then stented with a 3.5 into 20 stent, and then post OCT run I was there was no edge dissection, there was no malapposition, and everything was fine. But in the Lettman part, there was some studs was hanging. You will see it. Here there is no malapposition. Some part of the stent was hanging in the, yeah. So I decided to post dilate it with the pot for 4 into 17 in the Lettman part, and so there was a this was a good result. So emphasizing on the thing that imaging is very important and should be done in every cases, and to decide, because however it is not possible for us to always get it, but it is very important. Thank you, sir.
Thank
Very
you,
well done.
Dr.
Yeah.
We'll just introduce, he's just joined Dr. Prashanko Borua. Welcome, Dr. Borua. He's Senior Consultant Interventional Cardiologist at and
Dr.
Head of the
Kahali.
Department at Health City Hospital, Guwahati. Dr. Kahali, could you just comment on the case, and then we'll take ask
So
Dr.
the
Borua.
case was well done. He used IVL in both the cases, and the second one he has given it from the left main to the LED, did the pot properly. The result was good. The side branches were okay, and there was no malopposition, there was no dissection, so it was all right. But regarding the choice of IVL, why you didn't take rota or orbital and went for IVL? My question is too for the, there are many juniors, I believe, in this meeting, I heard. So for their knowledge, in which patients you are going to do rota, in which patients you would prefer orbital, and in which patients you would prefer IVL? Because IVL is very costly. I also do IVL frequently. I like it because it's less risky, I seem. To me, it seems less risky. But why IVL and why not rota?
Because sir, rota here I was in this case particularly I was thinking that rota is not so essential, because maybe the calcium is depth is also very much high. So whether rota will help or not, I was not sure. And actually the patient has also history of sudden cardiac arrest, and elderly I thought to go with the less risky thing, so I choice IVL in this case. And but obviously if the lesion will be uncrossable, then we have to go with the rota only, but all other cases orbital will be better, I think.
Dr.
Do you
Borua?
have any comments?
Dr. Borua, your comments?
Hello.
Yeah, we can hear you, Dr. Borua.
Okay, I think it's a good case, and I think imaging is required most of the cases, but I think not all cases. I think 20-30% of the cases, and I think he has done well. Hello.
Yes, we can hear
The
you.
results were very
Yeah,
good. Yeah, Dr. Borua, we do
done
agree
well,
with
yeah.
you. Yeah. The dilatation were good and the apposition was good.
But
There
sir,
was no
I want to ask
malapposition.
one question, sir. There was a balloon rupture, IVL balloon rupture, when I given the 30 pulse of.
Yeah, I heard about it.
But I don't know why it happens.
It
Everything
happens,
was.
in IVL also rupture happens, like other
So,
will.
so this was
It's
my
not that
experience.
frequent, but it happens.
I am
I
telling you,
have
Dr.
seen in
Because
our center, didn't happen with me.
yeah,
I am fortunate in that way, but it do happen. It has happened with some
but
of my
around
colleagues.
4 or 5. Can I share my experience on IVL, sir? So
Yeah.
it was around 4 and 5 years back when IVL came into the market. So Tiso was again with me. So we were doing IVL quite enthusiastically. The first thing of balloon ruptures is again the calcium spicules. And the imaging is must. Whenever you are doing imaging, if you see calcium spicules coming within the vessel. So the most important thing what Sir was asking is that whether the calcium is concentric or eccentric. If you are having adventitial calcium, if you are having distal calcium, it is always preferred to go for an IVL because you will dilate the vessel, you will prepare the bed of your own. But the thing is that if you compare rota versus your orbital, if you have a tortuous vessel, if you have a discrete calcium nodules, then orbital is preferred because your rota has a propensity to stuck. So your orbital will not stuck. Even if it's stuck, you can cut you back. You can pull your orbital back with the same speed from distal to proximal, which your rota will not do. It will cut only from proximal to distal part. So this is the difference between orbital and rota and IPL versus orbital. The thing is that if we consider IVL,
Orbital
if
is
you are
little better in
yes
ostial
sir.
lesions,
So if
while
you
coming it cuts with
yeah.
the
So if you
diamond
consider
spicules.
IVL, before going for an IVL, you must see whether there is calcium spicules, whether you are uneven calciums within your vessel. Then you should not
Yes, but
dilate your
in my
dilate
case,
your.
there was no tortuosity.
But
There was
there
no
must
tortuosity and there was no spicules
yeah
and also concentric type of calcium. Still,
yeah.
the balloon get rupture just on 30 pulses
Now
and
how much you dilated? 4 atmosphere or 6 atmosphere?
4 atmosphere only
In four
because
atmosphere, if it ruptured, then you are unlucky enough.
yeah, yeah. But
Dr.
whether it can
Kripashendu,
hurt the sir,
Dr.
whether it,
Kripashendu,
yeah, yeah, sir.
I'll just give you a tip for this balloon rupture.
Yeah.
Yeah.
Be very friendly with your distributor. He'll give you a free balloon. So just make sure of that. This is very important.
Yes,
Yeah.
sir.
So if you negotiate well, the balloon rupture probably has, it could be spicule, but at some point of time in initial stages, balloon was rupturing for
Yeah,
no
Another
reason.
another cause
So
of balloon rupture may be in the air within the balloon. If you do not prepare your balloon properly,
yes, sir. Yes, sir.
if you have air, then if you evaporate that air, it has a tendency to rupture again. So always prepare your balloon
So
fully.
always very careful preparation of the
Yeah,
balloon beforehand. That's very important. You must
Yes, if the
be
emitter is
free
if
of
the
air.
emitter is very much near to the balloon material, then chance of rupture will be high. But if the this rupture can damage the blood vessel
not
in
not
or not,
no,
not,
no,
not,
no, no, no.
not.
There is no
No, it
barotrauma. It's
can.
only
It
four
can, Dr. Dev.
atmospheres.
Yeah, we have seen it can. It can. So if it is severe, it can. But normally it doesn't happen, of course, but it can happen. And one thing, rota should be kept for very critical lesions where no other wire goes, where the IVL balloon won't go, where orbital won't go. For those patients, I think rota is very useful. Very critical lesions. It's easy to negotiate the rota wire than the other ones.
Dr. Pandey, you will have your final say on this case, and then you can come on to your own case. Dr. Pandey?
Yes, sir. Thank you. So first of all, there had been some technological, changes of the IVL balloon. So the initial generation balloons used to burst a lot, but now it has come down significantly because the company has made some very important changes in the technology, the layer and all. So the chances of balloon rupture has gone down significantly. And second issue, IVL rupture as you are delivering the pulse at 4 atmosphere only. So the very if you're very unlucky, as Dr. Kahali mentioned, you may land up into trouble. But generally, rupturing this kind of balloon at 4 atmosphere do not cause huge trouble. But you need to identify because the once it is ruptured, the basic technology is no longer working. So you need to stop the procedure and take it out.
And also, you
And
have to
if
size
you are
the
like,
balloon properly, 1:1. So
yes,
that's very
that is
important.
very
If you
important. One
oversize
is
the
to one.
balloon, then it's
Yes.
problematic.
It's very important to size your balloon. It's very
Yeah.
important to prepare your balloon because if there is, air and all that are probably the cause. But now after the technological changes, chances and incidents has gone down. And if you are very lucky, like Dr. Dev, you'll get another balloon from the, distributor, which doesn't happen to us somehow. So anyway, very good case, nice case.
Very well
So,
done, Kripa Sindhu. So we can go to Arindam. I think you are the last presenter.
Yes,
yes.
sir.
So kindly present your case.
Yes, sir. Thank you. It's always a pleasure to present in front of very august gathering, including Dr. Dev, Dr. Borua, and Dr. Kahali. Thank you very much, Abad, for this opportunity. I actually wanted to present one OCT guided
Thank you, sir.
case, but
Thank you.
that is somehow not technical, due to some technical glitch. The OCT images are not running, so I'll show another case. So this is a case, 82-year-old doctor himself. He was from Jhargram. Still he used to practice, but had a very terrible angina. So admitted, propagi was mildly elevated, ejection fraction somehow was preserved. So angiography actually was done in another center. I'll show you the angiography. This was the image of the angiography. The CD was not running in my computer, so I have taken a mobile clip of the CD. You can see the kind of trifurcation lesion in the left main distal. RCA somehow had minor plaque, but left system is very terrible, and you can clearly see the calcification. So how do you understand from the angiographic image your calcification is very significant? So first of all, you can see the calcium. I'll just stop here. So if your calcium actually is seen during moving image, visible calcium in fluoro, then you understand it is a significant calcification. Now, if I'll stop. So if you're this calcification, if you stop the fluoro image, still it is persisting, or if there is trump track calcification, so calcification of both the walls of the vessel, if you find this kind of calcification, that clearly indicate you have very significant calcification, and you need some form of imaging modality to estimate whether it is intimal calcification, medial calcification, or only adventitial calcification. And these are the patient you need calcium management tools, which is beyond just non-compliant balloon. So in this particular case, we used orbital, and very important difference between orbital wear and the Viper, normal rota wear. Though the rota wear now is also we are about to get very improved rota wear, because Boston has a collaboration with Asahi. The maneuverability of the rota wear, particularly rota floppy, is going to be different. It is available in other country. Our country, it will be very soon available. But a Viper wear, it is in the current form, is very easy, negotiable, wire. So this is not like stainless steel wire of the, rotablation. So you can see this was a difficult wiring. The LED ostium was very bad, calcified. So what I did, I engaged the LED ostium with a simple run-through wire, then followed by Viper wire, because ideally you are supposed to use a microcatheter and exchange it, but you can actually do the wiring with the Viperware. So that indicates how easily negotiable this Viperware is. And after this, initial IVUS run was not possible. We had to predilate with a 1.5 millimeter semi-compliant balloon to make some way for the IVUS. Then we took the IVUS in, and you can see the calcification. There are multiple areas where there was 360-degree calcification, and it had both intimal, medial, and adventitial calcification. The arc of calcification at some point was very, very huge, and at some point in the mid-distal LED, there was one nodule as well. So those were very important findings from the IVUS run. So we started the orbital atherectomy as per the plan. We can see the orbital bar is going down 1.25. It's a single bar. So like rotablation, the conventional rotablation, we have option of 1.25, 1.5, 1.75, even 2 millimeter bar. But in orbital, you need to change the rotation. So if you are rotating at 80,000, then the arc of cutting is lesser. If you increase the rotation RPM, then it will take a more wider area of cutting. So initially we went ahead with 80,000 RPM, followed by 1,20,000 RPM, and thus you can see your movements will be very small movement, forward and backward movement as well, because this particular technology, it can cut on the back side as well. So it has both front cutting and back cutting ability. So this is one of the very important difference between conventional rotablation and orbital atherectomy. So after the wiring, after the rotablation was done, LCX wiring was done. Then it was pre-dilated with a non-compliant balloon, 2.5. Then we went ahead to pre-dilate the LAD. So LAD pre-dilatation, you can see even after whatever form of rotablation or IVL you are using, you are supposed to use further non-compliant or cutting balloon. So this was a 2.5 non-compliant balloon. Cutting balloon was not used. And what was the consequence? I'll show you later. But the mid-distal LAD, where we found a nodule that actually did not open very nicely. Anyhow, we went ahead with the stenting of the LCX with a nanocross technique, 2.5 by 15 drug eluting stent. It was alpine stent, and you can see the nanocross. And after that, this was the result, the crossing, followed by pot, then distal LED stent, 2.75 by 24, followed by proximal LED stent. Now you can see the distal stent is not very nicely open. So that is another important additional information in this image. The positioning of the proximal stent was a 3.5 by 28 Giants Alpine. And this was the final deployment of the proximal stent. Pot with a 4 millimeter balloon at quite high pressure. Uh, but the problem is the distal stent of the LAD. You can see even after using orbital, the distal stent did not open. So we took another non-compliant balloon, 3 by 10 Ruri balloon, but still at a 28 atmosphere, it did not open. We can clearly see it is not open. So one mistake we did, generally nowadays what we have started, all cases of patients where there is very significant calcification, pre-dilatation should be more aggressive. So after whatever rota or orbital IVL, we should be using cutting balloon. So in this case, it was not done, only non-compliant balloon pre-dilatation was done. So for that, we had to take a OPN NC balloon, and that too at a 34 atmosphere. You can see on the left-hand panel, this is opening the distal segment. So we had to go very, very high. Then only we could open it, but this is little risky after deploying stent because the chance of perforation and all is high. So always better to pre-dilate properly. The distal LED now is seen. You can see the distal LED actually was a CTO, and we crossed the distal LED as well after finishing the proximal part. And we did a drug coated balloon only, 2 by 15 dCb. And after that final pot, kissing balloon was also done, and with the distal left main, then final pot. And you can see the distal LED CTO segment, there was not significant dissection or something. And the stent was well deployed. The MSA everywhere was very, very acceptable. And the lumen which was gained was very, very good. You can see the eye was pulled back. The proximal LED, the left main. This was the final result. Everybody will appreciate. The symptom of the patient gone. You can see the initial presentation and the final result.
Very well done. I think the results are gratified
Okay.
because the lesion was very, very severe. It was practically not seen anything. Heavy calcification in the distal left main, the ostium of the LAD, the ostium of the circumflex. So it was heavy calcification. And you have done a very good job, and it was well done. But
Thank you.
one thing, Arindam, I was little surprised that orbital is one of the instruments among the three, which is very good in dealing with the nodules. So
Nodule,
why
yes, sir.
it didn't heal? That is the question.
So yeah, so though it is said that probably orbital is the best tool nowadays to deal
Yeah.
with the nodule, but in some of the cases, nodules are very difficult. Some of the cases, nodules can give you a lot of pain. And I have seen in live case in different seminars as well. Even after using both rota, either conventional rota orbital plus IBL, sometimes the nodule do not give away. So yes, this is probably the best tool, but not all cases are same.
Yeah, the Swiss, operators, they are very fond of this high pressure balloon because OPN is probably a Swiss balloon.
Yes, sir.
And
Sure.
Fokuli, he came to our center quite a few times, and he was telling that they go for very high pressure inflation, 45, 50. So I asked him, how many perforations you have done? Well, fortunately, not too much, but few, of course. So, though it's told that OPN, because of its double layer, etc., it doesn't cause perforation, etc. But at very high pressure like that, it can happen. But they're also very good. Though it's our, one TCT trial has come. I forgot the name of the trial. And there they have shown that orbital and balloon dilatation with NC balloon, both are equipotent. But I doubt that state. Without cutting in a severely calcified lesion, balloon doesn't work. Foucault are also talking like that, that with this focal, of course, focal calcification, not, a long segment calcification, they can't dilate like that. But in focal calcification or semi-focal calcification, these balloons, these high pressure balloons like OPN you have used, they're very good. And they are claiming, and probably, I don't know what was the percentage of the balloons they used in this study, what was presented in TCT, but I doubt that how many balloons open like that. Because the balloons has got dog boning effect, therefore we have gone to atherectomy. And atherectomy is so popular nowadays that everybody is doing atherectomy and IVL also.
Yes, sir. IVL
So
has
that is
become really
the thing,
popular.
that calcified nodule doesn't give to
Mhm.
anything and everything. Sometimes orbital is the best instrument, as Arindam was telling, but it didn't give away, and finally it gave away to OPN balloon at very high pressure.
Dr. Borua, your comments? Please
Sir, you
unmute
are
yourself.
mute. Please unmute yourself.
Yeah, Dr. Pandey, it's a very nice case. I've seen, yeah, nicely done. And I think the orbital atherectomy is a system to stay. And as Dr. Kahali has said, that it can manage even now can manage the nodule as well as also it can also to modify the no deep calcium. So I think it is a device to stay. And for me, actually here actually in Guwahati, I'm not doing it regularly, but it's my learning curve. And I think orbital atherectomy, if we can go ahead properly, I think it's a nice device, and I think we can avoid we can optimize the results of the angioplasty. And I think I thank Dr. Kahali, Dr. Dave, yourself, and all Dr. Pandey, Dr. Datta, Dr. Moria, and it's a nice meeting. Thank you so much.
All the three presenters have done beautifully well, and the cases. Arindam, you have only one case or another case?
No, sir. Only one case for today.
Only
Another
one
case
case.
is
Very
not
Just
running.
beautiful
The
one
case you
procedure.
have
comment,
done. Yes,
Devanda,
it's
just
really
one
a
comment.
nightmare for any operator. That nothing was seen. I had some cases like this, but it was extraordinarily heavily calcified lesion. Nothing was visible. Practically, the LAD, distal LMC lesion was so tight. But had the patient developed any hypotension during the procedure?
No, sir. Patient did
No,
not
that's
develop
you are
any
fortunate
hypotension.
here,
Somehow, I
because
was
these
very
are the
fortunate.
patients
Though,
who develop all
yeah.
sorts of complications, bradycardia, hypotension, severe chest pain, sometimes going to shock like that.
Mhm.
So you are
Right
fortunate.
coronary was good, probably that given some
Yeah,
support. Otherwise,
the
this was a
support
very
was good.
nasty kind of.
Support was good.
Dr.
Mhm.
Pandey,
But
one question for you. Uh, your stent didn't open even after
Mhm.
the orbital. So, what do you think about the compliance test, which some people suggest after the orbital or after an atherectomy? If you do a compliance test with a 1:1 balloon, and
Mhm.
then actually you have a chance of not putting the stent and then going for it. It is better to prepare the bed. So, what do you think about the compliance test?
Yeah. So there are multiple ways you can actually check whether you have done good bed preparation. So most importantly is the imaging. So in our case, what we did post atherectomy imaging, which actually shown there was very nice cracks in the circumference calcification. So that boosted our confidence. But to be very honest, second option is to see how your balloons are opening.
Yeah.
So our non-compliant balloon in the mid-distal LED did not open, but we had, strong confidence on orbital and our imaging of the IVAS, which suggested there was nice crack, reverberation effects were good, lumen gain was very nice. So somehow now, after this case, what we have practicing, we have make it a mandatory to use cutting balloon, and also as you suggested to see the opening pattern of the cutting balloon, how it is opening. If it is opening very nicely, the cutting balloon, then your job is very nicely done. Otherwise, I think it is always better to prepare the bed nicely before putting the stent and go for post dilatation and all. That is the
And
thing
it's
to see.
always better to go for initial, balloon dilatation with a smaller balloon than to go for a 2.5 or 2.75, whatever you think, cutting balloon inflation at a proper pressure also. Because what is written in the cutting balloon 4-6 like that, that doesn't work. We go up to 14, 16. There is no limiting, it doesn't cause any perforation with that high pressure. But the blades open and the cutting is good.
Yes.
So that action is very good. And of course, Dr. Dev, I do agree that the bait preparation is very important, and we should take a good caliber, like if it is a 3.5 vessel, we should take preferably 3.25 or 3.5 balloon and dilate it well, not necessarily maybe at a very, very high pressure and causing some dissection and perforation, but at an adequate pressure and making the bed very good, so that there is no chances that the stent which is we are going to put implant is not dilated, is malapposed or under expanded. That doesn't happen.
Thank
In
you,
fact, some cutting
Dr.
balloon, they are coming up with a pressure of up to 24. So we are routinely going up to 18. 18 is good, but there are new balloons which will be available very soon. Cutting balloon with a burst pressure of 24. So
Yeah, as
that will
Dr.
be
Kahali just told, the nominal pressure which is written or the
it
rated
doesn't
burst,
work.
burst pressure which is written, it doesn't work. Cutting balloon has to go up and actually opposed to the vessel wall, otherwise it will not cut.
Yeah,
Yes.
because I have seen Dr. Shamin Sharma and many other operators like Dr. Ashok Sheth and Samuel and everybody, that they go for much higher pressure than what is written in the charts. It's very low pressure. We should go up to 12, 14, 16, whatever is required. It doesn't cause any complication, at least I haven't seen. But that causes the blades to open, to cut well, and to make a good bed and a good lumen, so that the further balloons can dilate, and the stent will be wide open.
Because more than the diameter, the fractures are more important
Yeah,
for the
fractures are
expansion of
more
the stent.
important.
That is very, very
Exactly,
important.
exactly. So unless it is at an adequate pressure, they can cut. They can't cut. That's the main thing.
Thank you very much, Dr. Pandey, for your excellent presentation. I wish to thank Dr. Kahali and Dr. Borua for
Thank you,
giving their
Dr.
time.
Dev, too, for your nice moderation. And it was a fantastic seminar. And thanks the award people also. All the three presenters were beautiful. All the cases were well done, well selected, and well presented. They were not hesitant to show the complications as well. So it was a very nice thing, very nice learning curve.
Okay. Okay. Good night, everybody.
Thank you,
Thank
Good
you.
everybody.
night,
Good
everybody.
night.
Thank you so much.
Good night,
Thank you.
everybody. Good
Good
night.
night.